Welcome to this presentation on evidence-based treatments for bipolar disorder in children and youth. I'm Dr. Christopher Balanci, Medical Director of the National Technical Assistance Network for Children's Behavioral Health, and I'll be the host of this morning's webinar. I'd like to acknowledge my research assistant, Katie Stockman, for her work in preparing the content used in this presentation. So what are the criteria for juvenile onset bipolar disorder? And how do they differ from adult bipolar disorder? What are the evidence-based treatments for juvenile bipolar disorder? And what is the differential diagnosis? The Diagnostic Manual, or the DSM-5, provides no developmental criteria for bipolar disorder. That means that children have to meet the same criteria as adults. This has led to the so-called narrow definition, those children who meet the Diagnostic Manual's definition of bipolar disorder, or the broad definition, which still remains very much in debate in the field. Since the mid-1990s, there's been a sizable debate that mania in children and adolescents presents differently when compared to adults. Pediatric onset mania was theorized to present as severe, non-episodic irritability with extended periods of very rapid mood cycling within the day versus discrete mood cycles, which is more classic of adult bipolar disorder. With this broader concept of pediatric bipolar disorder in the United States, we've seen a 40-fold increase in the diagnosis over a 10-year period. Before the 1980s, it was rare to use psychiatric medications in children other than stimulants for attention deficit hyperactivity disorder. Prepubertal children were not thought to be able to actually even develop mood disorders. These were echoes of Freudian psychoanalytic thought and the concept that there was a superego necessary in order to have a depressive episode. Using a developmentally based biopsychosocial formulation to explain behavior in children was the norm. Today, we're increasingly under the belief that children's behavior can be primarily understood as biologically or genetically based, or at least some people believe that. Most psychiatric medications on the market are currently being used in children, often despite safety and efficacy studies specifically being done in children. And as mentioned, between the years of 1995 and 2004, research by Mark Olson and his team noted there was a 40-fold or 4,000% increase in the diagnosis of bipolar disorder in the United States. Looking at adult studies, we know that it can take on average 10 years for the diagnosis to be made and then treatment to be initiated. This creates a sense of urgency for timely detection and treatment given the significant morbidity, which is disease, and mortality, which is death, associated with bipolar disorder in adults. The key there is then trying to identify bipolar disorder in its earliest manifestations, and that's where the challenge in the field has come. So according to DSM-5, bipolar disorder is defined by having a manic episode, which has to be a distinct period of abnormally and persistently elevated, expansive, or irritable mood. And that mood has to last at least 1 week and be present most of the day and every day during that week period. It must also cause marked impairment in social or occupational functioning. So to meet criteria for bipolar I disorder, a patient must experience at least one manic episode. It's not necessary for a major depressive episode to have been present for the diagnosis of bipolar disorder 1 if the criteria for acute mania has been met. This is the so-called narrow definition. Additionally, for bipolar disorder, you have to meet 3 or more of the following: inflated self-esteem or grandiosity, decreased need for sleep, more talkative or pressured speech, flight of ideas or racing thoughts, distractibility, an increase in goal-directed activity or psychomotor agitation, and excessive involvement in pleasurable activities with a high potential for painful consequences. So I would ask the question, when you're thinking about a 5-year-old or an 8-year-old or even a 13-year-old, what does inflated self-esteem or grandiosity look like? What would it mean for a 5-year-old or an 8-year-old to have distractibility, which seems very non-specific, or an increase in goal-directed activity, or excessive involvement in pleasurable activities? And that's the challenge, is adapting these criteria to children as young as 3, 4, 5, some of whom have been diagnosed with bipolar disorder. Bipolar disorder type 2, which I'm not going to go into in the extreme, is really defined by the presence of hypomania instead of mania. And a hypomanic episode requires an elevated, expansive, or irritable mood, but it doesn't last as long. Instead of the 7-day requirement for mania, it can last for 4 consecutive days, but feature the same number of symptoms as in a manic episode. So as I mentioned, the field is challenged to know, how do you adapt these bipolar criteria to younger children, particularly those prior to entering puberty? You have to consider whether the presentation is a variation from baseline, as required by the definition. Is there a specific context in which the symptoms are becoming manifest? And given the normal developmental vulnerabilities of children, such as impulsivity or brief but intense changes in mood or short attention spans, how do you differentiate normality from pathology? Barbara Geller at WashU defined grandiosity as a child saying it's not wrong to steal after getting caught, or a child believing they can become a professional athlete even though they are not good at sports. And elation in children is defined as excessive silliness or giggling. I emphasize these points because they are so overly broad as to make the diagnosis very challenging in young children if this is the way we're going to adapt the adult criteria to be applied to childhood. It was in this context that we saw the 4,000% increase in the diagnosis of bipolar disorder. And what does it mean if a child only manifests the symptoms of mania in one setting, such as home or school? Can this still be considered mania? It's critically important in completing an assessment to gather information from multiple sources, including primary caretakers, the teacher or other school staff, the pediatrician who may have a longitudinal experience with this family, as well as any others working with the child, including the child welfare system if they're working with the child. So juvenile bipolar disorder evolved to seeing the following symptoms as evidence of the condition, and now we're starting to define what the broad definition would look like. So mood lability was being characterized as getting upset or angry for no reason or no apparent trigger, in excess of what the stimulus would imply. Irritability, reckless behavior, aggression, and very rapid but very brief recurrent episodes of escalated behavior that could last hours up until a few days. And this has been termed ultradian cycling. So rather than the up and down that you might see in a person with bipolar disorder in adults, where you have discrete episodes of mania that can last and need to last for at least 7 days, and then typically there would be a euthymic episode, a return to baseline functioning, and then there may be other depressive episodes interspersed. What we started seeing in the definition of juvenile bipolar disorder, using this broader definition, was this notion that within the day, the moods could be going up and down without any apparent external trigger. There has been meta-analytic studies trying to identify what the symptoms are that are consistent with pediatric bipolar disorder. And I would just suggest, as I run through the list, note the overlap with ADHD symptoms. So increased energy was present 89% of the time for children that were diagnosed with bipolar disorder. Distractibility, 84%. Pressured speech, 82%. Irritability, 81%. that notion of grandiosity, 78%, racing thoughts, 74%, etc. So picking up on the theme of bipolar disorder versus ADHD, you'll note there are no significant differences between the two in the conditions based on irritability. So 98% of bipolar youth had irritability, and 72% of youth with ADHD also represented or had irritability symptoms. Accelerated speech was present in 97% of bipolar youth and 82% for youth with ADHD. Distractibility, a little higher for ADHD, but very high for the bipolar diagnosed youth. And unusual energy, also high in both categories. So high that there was not statistical difference between those two. So one way of suspecting the presence of bipolar disorder in a child with ADHD is if the ADHD symptoms present later in life, if the symptoms appear abruptly in an otherwise healthy child, if the symptoms were responding to stimulants and now are no longer responding, if the symptoms come and go and tend to occur with mood changes, if a child with ADHD begins to have experiences of exaggerated elation, grandiosity, depression, a lack of sleep or need for sleep, inappropriate sexual behaviors, if you start seeing recurrent severe mood swings, temper outbursts or rages, the presence of hallucinations or delusions, which would clearly not be consistent with an attention deficit hyperactivity disorder, or in the presence of a strong family history of bipolar disorder, as it does seem like there's a genetic risk factor associated with the development of bipolar disorder. Irritability keeps popping up in relation to the diagnosis of bipolar disorder as one of the seminal characteristics. Again, it's very difficult to define irritability, and it's a fairly nonspecific construct, although the field is trying to make that more well characterized. And I'll talk about a couple of longitudinal studies that have tried to look at that. But irritability, according to Ellen Liebenluft at the National Institutes of Mental Health, is an emotional state characterized by having a low threshold for experiencing anger in response to negative emotional events. So there's a low threshold to the anger, a faster increase in anger, a higher peak level of anger, and a longer duration of anger. And that started becoming part of the construct, that broad definition of bipolar disorder, based on what we were seeing coming from the research. Irritability has a high sensitivity for bipolar disorder, being present in anywhere from 55 to 94% of youth, depending on the study. But it's not terribly specific to bipolar disorder. So other diagnostic categories where irritability shows up include the disruptive behavior disorders, depression, anxiety, and post-traumatic stress disorder. And it can also even be seen in ADHD and pervasive developmental disorder. Looking at differential diagnoses for bipolar disorder, we have everything from ADHD and oppositional defiant disorder or conduct disorder. Those are the disruptive behavior disorders I just mentioned. Even learning disabilities, so language and nonverbal learning disability, trauma, substance abuse, autism spectrum disorders, disorders of attachment, and psychotic disorders can all sometimes present with some of these aspects of the broad definition of juvenile bipolar disorder that I've been discussing. Over 50% of youth who develop bipolar disorder had a prior history of a major depressive episode. Often it's thought that depression would precede the onset of the manic symptoms, which can raise concerns about treatment with antidepressants, particularly serotonergic agents like Prozac, Zoloft, Celexa, and Lexapro, as these are known to increase the onset of bipolar or manic symptoms. So it can be challenging if you have a youth who's first presenting with a depressive episode to know whether or not by treating their depression with an SSRI, are you putting them at risk of manic activation or manic switching? And so the field is encouraged to look at family history, or the context of a new onset depression, one should consider family history, and if there's a family history of bipolar disorder, one should be thoughtful about whether or not to use an SSRI, as it can be associated with manic activation in the context of a young person who has a genetic vulnerability and is predisposed to developing bipolar disorder. Looking at the epidemiology, we note that up to 50 to 66% of adults with bipolar disorder report onset of symptoms prior to age 20. Lifetime prevalence in adults averaged almost 4% of the U.S. population and about 2.5% in youth. Some studies report rates of bipolar disorder in youth averaging 1 to 2%, but if you broaden that to the broad definition, you can see rates as high as 6%. This is also dependent upon variability in study techniques and the populations being surveyed, and that's why we see such a large range. Looking more globally, are we seeing these rates of bipolar illness in other countries? And the answer in short is no, we're not. After controlling for cross-national differences in lengths of stay at hospital, discharge rates, etc., bipolar disorder was 12.5 times higher in the United States versus the United Kingdom, according to one study from 2014. Comorbidity means the presence of two disorders at the same time. So in this case, we'd be talking about bipolar disorder co-occurring with ADHD, or attention deficit hyperactivity disorder. And that can occur 60 to 90% of the time that both conditions would be present. Now, some of that may have to do with the diagnostic overlap. Disruptive behavior disorders, conduct disorder, and oppositional defiant disorder can occur anywhere from 50 to 88% of the time concurrently with bipolar illness. Anxiety disorders, we also see a significant overlap with bipolar disorder, 75% of the time using adult studies. Substance use disorder, 50% of the time using adult studies. And then other comorbidities can include obsessive compulsive disorder, post-traumatic stress disorder, and pervasive developmental disorder. So what are the functional consequences of a diagnosis of bipolar disorder for youth? We typically see impacts in all realms of the young person's functioning. So in school, bipolar disorder is often associated with poor academic performance, disruptive school behavior, even neurocognitive deficits as compared to their healthy peers. Socially, we see decrease in peer support, risk for peer victimization, poor social skills as compared to their healthy peers. And in the family context, we see strained relationships, low levels of cohesion, and increased conflict. So there's significant morbidity and mortality associated with the diagnosis of bipolar disorder. Again, why it's so urgent for us to make the accurate diagnosis as early as possible and initiate treatment to try to avert long-term bad outcomes. So as mentioned, substance use is high in this population. There are high rates of hospitalization and suicide attempts, and in fact, the lifetime suicide risk is 15 times higher in individuals with bipolar disorder as compared to the general population. That's mostly from adult studies. Bipolar disorder may account for 25% of all completed suicides, according to one adult statistic. The World Health Organization indicates bipolar disorder is the fourth leading cause of disability in people aged between 10 and 24 years old worldwide. So we're talking about a significant public health problem. There are various assessment instruments that are used to help make the diagnosis accurately. The Kitty Schedule for Affective Disorders and Schizophrenia for School-Age Children, or the KSADS, is one version. It's a structured interview. It's lengthy and time-consuming and is mainly used in research for that reason. There are also symptom checklists based on the diagnostic manual. Rating instruments can be used to determine the level of impairment associated with bipolar disorder. So one rating instrument is the Young Mania Rating Scale, which is derived from the KSADS. There are also parent report instruments, the General Behavioral Inventory, which is the parent version of the Youth Mania Rating Scale, and the Child Mania Rating Scale for parents. These are primarily screening tools, and specificity is yet to be determined, meaning they don't make the diagnosis on their own. There had also been thought to be a bipolar profile within the child behavior checklist. This was a pattern of elevated scores in the domains of aggression, attention, delinquency, and anxious and depression that was postulated to be a marker for juvenile bipolar disorder. But the sensitivity was found to be significantly lower than that of the mania-specific instruments and has now largely been discounted, being viewed more as a dysregulation profile, if you will. Looking at the course and outcome, one study by Boris Bermar from the University of Pittsburgh in 2007 showed that 70 to 100% of children and adolescents with bipolar disorder will eventually recover from their initial episode, and that was defined as no significant symptoms for 2 months. The issue is that bipolar disorder is a cycling mood disorder, so it's not uncommon to have periods of euthymia of 2 months or longer in between episodes of depression and mania. So the same study also noted that up to 80% of the youth will experience one or more recurrences in a period of 2 to 5 years. So does the juvenile version that we were talking about, this broad version, where we're trying to define what grandiosity and irritability look like in young people, does that go on to develop into the adult version where there is greater diagnostic specificity? And this has caused a lot of consternation in the field as we try to answer this question, because typically you would not grow out of bipolar disorder. So we should see 100% correlation between the youth that we're diagnosing pre-pubertally with bipolar disorder going on to develop that same bipolar illness into adulthood. In the late 1970s, researchers were suggesting that 20% of cases had symptoms that were present prior to age 9. More recent studies are suggesting that as many as 50% of cases have their origins in adolescence. And so we should be able to identify who those youth are and initiate treatment and interventions and supports and services to prevent a worsening of that disorder as they transition into adulthood. There was one small 6-year follow-up study from Australia where they looked at youth, all males in this particular study, who presented with both symptoms of ADHD and mania. And as I said earlier, that's pretty common that you would have an overlap. And they identified 15 youth in that cohort. They had 65 youth who were diagnosed with ADHD only, and they had 17 controls. And at the start of the study, the ages were 9 to 13. And 6 years later, the youth were now 15 to 19. So how many youth originally diagnosed with mania continued to meet the criteria 6 years later? And the answer was only 1, which was a bit shocking, as you shouldn't grow out of a bipolar diagnosis. Within the ADHD group of 65 youth, 3, or approximately 5%, went on to develop mania. That's less surprising, as often we can see symptoms of ADHD almost as a precursor to the onset of the manic symptoms that present later in adolescence on their way to a bipolar diagnosis. What was also notable was they looked at global functioning across all 3 cohorts. And the controls obviously were well functioning. The youth with ADHD also continued to do relatively well, but this youth that had been diagnosed with ADHD and mania, those 15 youth, had significantly lower functioning at follow-up 6 years later. So they were obviously capturing something in that cohort that was associated with pretty significant psychopathology, as we're seeing in some of these other studies. But they raised the question of whether or not we were prematurely assigning a bipolar diagnosis for a population that, in fact, did not have bipolar illness, or at least did not go on to develop bipolar illness in adulthood. And you'll see this same concept come up in some of the other larger multi-site studies done in the United States. So looking at genetics, we can look at what we can learn from twin and adoption studies. And those studies show that first-degree relatives of adults with bipolar illness are at an 8 to 10-fold increased risk of developing bipolar illness compared to first-degree relatives without bipolar illness. So the offspring of bipolar parents have between a 5 and 15% lifetime prevalence of bipolar illness. So that's where I was mentioning if you have the onset of depression in the context of a youth whose one or more of their parents have bipolar illness, then they are at increased risk. But it's still a 15% lifetime prevalence. It's not anywhere near 100%. So it doesn't mean that if your parent has bipolar disorder, you will also have bipolar disorder. You just have an increased risk compared to the general population. These youth are also at increased risk to develop other disorders such as depression, anxiety, ADHD, and behavioral disorders. We have been trying to find the genetic link to bipolar illness. Heritability is determined to be about 80%, which is very high. Some of the suspect sites on various chromosomes are listed here. But the notion that we're going to find a single site of genetic variants that will account for all the cases of bipolar illness is increasingly unlikely. We've also been looking at the brains of individuals with bipolar illness through neuroimaging studies. And in general, we're seeing some white matter hyperintensities in the cortical and subcortical regions. There are smaller volumes noted in the amygdala and hippocampus regions, and reduced gray matter volume in dorsolateral prefrontal cortex, but the clinical significance of these findings is yet to be determined. Looking at neuropsychological functioning or neurocognitive functioning, several cognitive deficits have been found associated with bipolar illness, including difficulties in attentional set shifting, visual spatial memory, verbal memory, and executive function. And again, you'll see the correlation with ADHD in those areas of deficits. These studies are preliminary and include small samples, so I wouldn't make too much of that, and certainly they're not able to be used in the diagnostic way at this time. So the LAM study is one of these large multi-site studies. There were 10 sites funded by the National Institutes of Mental Health. Very large for a child psychiatric study. There were 707 children enrolled across the two groups. And they defined one cohort as having elevated symptoms of mania. And these were defined as rapid mood swings with high energy. So not necessarily bipolar disorder, but these were youth that had elevated symptoms of mania using this rating scale. It's the parent version of the Young Mania Rating Scale, the PGBI. And entrants into the study were followed every 6 months for 5 years. And what was found was that although elevated symptoms of mania were associated with higher rates of bipolar disorder, 3/4 of the population of youth who had elevated symptoms of mania did not ultimately meet criteria for bipolar disorder over that 5-year study period. So again, similar to the Australian study, we were seeing youth with elevated symptoms of mania showing poorer overall functioning, but not necessarily developing bipolar disorder, or at least in 3/4 of the cases, that wasn't the outcome. So the conclusions from the LAM study suggest that elevated symptoms of mania are common, and that they're associated with elevated rates of mania, indicating a potential use for screening. But they're also associated with non-bipolar diagnoses. And what the youth who had elevated symptoms of mania did go on to develop was 76% of the time ADHD. So again, we're seeing that increasing or that constant overlap with ADHD. Disruptive behavior disorders, mood disorders in about 40%. So bipolar disorder 11%, and then bipolar disorder not otherwise specified, which was still an eligible diagnostic criteria in the DSM-4. That's no longer the case in DSM-5 of 12%. And then anxiety disorders in 31%. So elevated symptoms of mania may be a marker for disruptive behavior with mood symptoms. And although I'm not going to go into it in detail in this presentation, I would encourage you to look at the diagnosis of disruptive mood dysregulation disorder in the context of this study, as that might capture some of these youth who were having elevated symptoms of mania but didn't go on to develop bipolar disorder. And that's a new diagnosis in the DSM-5. Another multi-site NIMH-funded study was the Course and Outcome of Bipolar Youth study, or COBE study. This enrolled 263 youth between the ages of 7 and 17. And its purpose was to assess the clinical presentation and family history of children and adolescents with either bipolar type 1, bipolar 2, or bipolar not otherwise specified. The minimum inclusion criteria for the bipolar not otherwise specified group were subjects who did not meet the DSM-4 criteria for bipolar 1 or 2, but had a distinct period of abnormally elevated, expansive, or irritable mood, plus the following. So they had 2 of the DSM manic symptoms instead of the 3 that would be required for the diagnosis. There was a clear change in functioning, which is a really critical aspect of making this diagnosis. The mood and symptom duration was a minimum of 4 hours within a 24-hour period. So instead of most of the day for 7 days, this was part of the day for a minimum of 4 days. So they basically adjusted the threshold of the DSM diagnosis to try to capture these youth who they were characterizing as bipolar disorder not otherwise specified. So as this notes, the duration criteria was really the primary variant. There were no significant differences among the bipolar 1 and bipolar 2 NOS groups in terms of age of onset, duration of illness, lifetime rates of comorbid diagnoses, suicidal ideation, and major depression. Family history and types of manic symptoms that were present, also there was no difference. So compared with youth with BPNOS, subjects with bipolar 1 had more severe manic symptoms, greater overall functional impairment, and higher rates of hospitalization, psychosis, and suicide. So they were sicker individuals. Their symptomatology was more intense compared to those characterized as bipolar not otherwise specified. Elevated mood was present in almost 82% of the subjects with bipolar NOS versus 92% of subjects with bipolar 1. So again, if you think about hypomania, this is almost a correlate of that, if you will, although that would be bipolar type 2. But it's a less severe form of bipolar 1 was what the COBE study was able to characterize. And they were suggesting that based on the COBE study, bipolar not otherwise specified and bipolar 2 were basically a phenotype that was on the continuum with bipolar 1, and that elevated mood is a common feature of youth within the bipolar spectrum. So now let's switch to the treatment of bipolar disorder and discuss what the evidence base is for the treatment, particularly focused on juvenile bipolar disorder. Unfortunately, there remains a scarcity of data regarding evidence-based treatments for pharmacologic and psychotherapeutic approaches to treating bipolar disorder in children. The approaches currently reflect, in large part, treatment in adult populations that we are then extrapolating down to younger children. A review and meta-analysis of psychopharmacological treatments for pediatric bipolar disorder examined between 1989 and 2010 found 46 clinical trials of anti-manic agents for pediatric bipolar disorder, 29 of which were open-label trials, which is about the lowest level of scientific rigor, whereas 17 were randomized controlled trials, and that's really what we hold as the gold standard in any research paradigm. So choosing your treatment approach, and this comes from the American Academy of Child and Adolescent Psychiatry's practice parameter on bipolar disorder that was primarily written by Jack McClellan at University of Washington, but was the work of the Quality Issues Committee of ACAP, of which I'm a member. So first-line options when managing clear bipolar 1 disorder ACAP would state that pharmacotherapy is the primary treatment option. And this is why it's critically important to get the diagnosis right, because the kinds of medications we're using in the treatment of bipolar disorder, such as antipsychotic and mood-stabilizing medications, carry with themselves significant risk of side effects, including obesity, risk of diabetes, risk of heart disease, primarily associated with the antipsychotic class of medications. So we want to get this right. And we also don't want to miss other opportunities for non-pharmacotherapeutic interventions. And if we think that the young person has bipolar disorder, pretty quickly we're focused on what's the medication combination that's going to be most effective. And often we forget some of the psychosocial therapies and other aspects of systems of care approaches that might be equally beneficial or perhaps even more beneficial in the course of treating this young person's condition. Remember that even in the longitudinal cases where we got the diagnosis wrong, those were individuals we were identifying who had significant morbidity and significant negative outcomes over the course of the studies. So we want to be able to intervene more holistically in the care of these children and not just focus on what the medication combination needs to be. So while pharmacotherapy is the primary treatment intervention, medication alone may not address the functional and developmental consequences of bipolar disorder. And therefore, adjunctive psychotherapy is almost always indicated for pediatric bipolar disorder. And again, that actually comes from that same ACAP practice parameter. So what are some of the psychotherapies that might be considered for a young person diagnosed with bipolar disorder? They would include cognitive behavioral therapy, family-focused therapy, interpersonal and social rhythm therapy, and psychoeducation. Only 2 psychotherapies showed efficacy in randomized controlled trials, and those would be multifamily psychoeducation group psychotherapy and family-focused therapy. So child and family-focused cognitive behavioral therapy, the treatment acronym is RAINBOW, which stands for routine, so develop routines, affect regulation, so that would include psychoeducation about feelings, mood monitoring, coping strategies to improve regulation. The I stands for I can't do it, improve child self-esteem and parent self-efficacy. The N in RAINBOW stands for no negative thoughts, live in the now, so cognitive restructuring or mindfulness to reduce negative thoughts. The B stands for be a good friend or a balanced lifestyle, which can include social skill building for younger children or improving self-care for adolescents. The O of the RAINBOW stands for, oh, how do we solve this problem? So that would include family problem solving and communication training. And the W stands for ways to find support, which would include encouraging support networks. This RAINBOW approach is a 12-week manualized 60 to 90-minute sessions that include the parent, child, and family. And it can combine traditional CBT features as well as others as I've outlined. Medication management can include traditional mood stabilizers. That would be medications like Lithium or valproate, which also goes by the brand name of Depakote, or atypical antipsychotic medications as the primary treatment options. Other psychotropic agents and psychotherapies generally used as adjunctive therapy or to address comorbid conditions. So that would include medications to treat anxiety, medications to treat ADHD, although one has to be careful that any of the medications used to treat the comorbid condition doesn't make the mania worse. And that would typically be seen as more rapid cycling and more extremes of manic symptoms during those episodes. Treatment should begin with an agent that's approved by the Food and Drug Administration for bipolar disorder in adults, recognizing that the evidence of the efficacy for these agents in children and adolescents is sparse at best. There are now indications for a number of the atypical antipsychotics down to age 10 that I'll discuss. So Lithium is approved down to age 12 years for acute mania and maintenance therapy, according to the FDA. Lithium's certainly been around for a very long time, and has a proven track record in adults, and is particularly known to decrease risk of suicide during the active treatment with lithium. And that's obviously an important point in a condition that is associated with a 15% mortality rate by suicide. The next group are the second generation or atypical antipsychotics, and that would be aripiprazole, which goes by the brand name Abilify, risperidone, quetiapine goes by the brand name Seroquel, and asenapine, which goes by the brand name Saffris. That's the newest agent on the block. These have all been approved for acute mania in children down to 10 years old or older. Olanzapine, which goes by the brand name Zyprexa, is approved for youth with mixed or manic states greater than 13 years versus the others that go down to age 10. Chlorpromazine is Thorazine, which has been approved for acute mania in children, very young children, but is generally not used as a first-line agent. And they were kind of grandfathered into that approval status. There were no more current studies looking at the use of chlorpromazine in mania. Lamotrigine is an anticonvulsant mood stabilizer its brand name is Lamictal, and olanzapine are both approved for maintenance therapy for bipolar disorder in adults. And then the combination of olanzapine and fluoxetine is approved for bipolar depression in adults. And bipolar depression is particularly tough to treat because it's hard to get at the depression with an antidepressant without worsening the activation or the manic side of the bipolar illness. So traditional mood stabilizers, as I've mentioned, medications like lithium or some of the anticonvulsant mood stabilizers show some limited evidence for efficacy for the treatment of pediatric bipolar disorder. And there's a narrow therapeutic index range. Response rates for manic symptoms average around 40%, which is obviously not what we'd like to see. We'd like to see response rates up above 50% or even as high as 70, 80, 90%. Lithium, as mentioned, shows a response rate of around 40%. And as a publication of the meta-analysis and review in 2011, there were no double-blind studies for response rates for lithium as monotherapy. So while lithium is the standard bearer in adult bipolar treatment, there's less evidence of efficacy in children. That doesn't mean it doesn't work, it just means we don't have as many studies to show its efficacy. Common adverse effects of lithium can include nausea, vomiting, an increase in appetite, which results in weight gain, headaches, and stomach aches. And there are monitoring that needs to happen because lithium can be associated with renal disorder. So checking complete blood counts. Lithium can also cause hypothyroidism, so checking thyroid function tests, and then looking at kidney function to make sure that the lithium is not impairing kidney function. And it's always important to test for pregnancy, as lithium can be teratogenic for the developing fetus. Ongoing, you would want to check lithium levels, kidney function, thyroid function, and urinalysis approximately every 3 to 6 months. And then the anticonvulsant mood stabilizers. So these are seizure medications that have been used for mood stabilization. And again, there was a long history of using these medications in adults before we started using them in children. Carbamazepine, which goes by the brand name Tegretol, there were only 2 trials. Both were open label, so not the highest level of scientific rigor. And the response rates, again, were about 40%, with common adverse effects of nausea and sedation. Valproic acid, which goes by the brand name of Depakote, had 8 open-label trials and 3 double-blind trials, showing an average response rate across those trials of about 43%. The study of Depakote and lithium as maintenance medications post-stabilization showed no benefit to one over the other. And monitoring for valproic acid would include liver function tests, complete blood counts, and then pregnancy tests. It's also important to note that valproic acid has been associated with the onset of polycystic ovary disease when used in prepubertal females. And so that's a cautionary note about the use of Depakote for young women. Ongoing monitoring for Depakote would include serum drug levels, plus hepatic, which is liver, and hematologic indices. and those should be done roughly every 3 to 6 months as well. There are other anticonvulsant mood stabilizers that have been used for the treatment of bipolar disorder, including lamotrigine, which goes by the brand name of Lamictal. There was only one study for lamotrigine as an anti-manic agent, and the response rate was 54% in this open-label study. Common adverse effects can include gastrointestinal symptoms, headaches, and skin rashes, and particularly you want to look out for an extreme acute onset of a rash called Stevens-Johnson syndrome, which can be fatal if not addressed early. And then oxcarbazepine or trileptal is another anticonvulsant being proposed as a mood stabilizer. There was one double-blind study of oxcarbazepine's use in pediatric bipolar disorder, but it didn't show any greater efficacy than placebo, and that's why I say it's been proposed as a use. We don't actually have any studies that indicate that trileptal is effective for juvenile onset bipolar disorder. And common adverse effects can include dizziness, nausea, somnolence or sedation, double vision, fatigue, and rash. And then topiramate, which goes by the brand name Topamax, is again an anticonvulsant mood stabilizer. There were 2 open-label studies and 1 double-blind study. And the 2 open-label studies looked at topiramate's efficacy in decreasing the second-generation antipsychotic weight gain. So with those atypical antipsychotics or second-generation antipsychotics, there's been significant weight gain associated with their use. And so some individuals have been using Topamax or topiramate to try to treat that weight gain, with both studies, open-label studies, showing efficacy. One study also showed the addition of Topamax lowering the Young Mania rating scale scores, but the other didn't. So mixed results in terms of whether or not it actually helps with mania. And the only study of topiramate for the treatment of bipolar disorder alone didn't separate the active treatment group. So again, similar to trileptal, we don't really have evidence that topiramate is an effective anti-manic agent for juvenile onset bipolar disorder. It may help with some of the weight gain associated with the antipsychotic medications. So let's now discuss those antipsychotic medications. First-generation antipsychotics are also called typical antipsychotics. Those were the first antipsychotics discovered back in the 1950s. And those would include medications such as thorazine, Mellaril, thorazine is chlorpromazine, and then Haldol was a later entry into the antipsychotic armamentarium. Common side effects of these medications can include dry mouth, sedation, and the most important one is extrapyramidal side effects, which can include tardive dyskinesia, which can be an involuntary muscle movement disorder. And then in rare but severe side effect can include neuroleptic malignant syndrome. They've largely fallen out of favor because the second-generation antipsychotics, which arrived in the 1980s, were offered as an option that would reduce the risk of these movement disorders, extrapyramidal symptoms, and other significant side effects of the first-generation antipsychotics. And they were also professed to be more effective, although in truth now, having had 20-plus years of study, it's not clear that they're any more effective, and it seems like, at least for youth, we've swapped out side effect profiles where the first-generation antipsychotics were more harmful in the sense of side effects of movement disorder. The second-generation antipsychotics seem to be more harmful in the concept of weight gain, obesity, diabetes risk, and heart disease risk. So the second generations have a stronger therapeutic profile and were thought to have a larger margin of safety compared to mood stabilizers for the treatment of pediatric bipolar disorder. However, a summary by AHRQ in 2015 shows that second-generation antipsychotics probably decreased mania and depression, although it was a slight decrease. And they tend to look at all the existing literature and then do this meta-analytic study. They probably improve symptom severity and global functioning to a small extent. They probably increase response and remission rates compared to placebo for mixed and manic states. And of note, 15 of the 18 trials had follow-up periods ranging from 3 to 12 weeks. So several within study group, subgroup analyses show that concomitant use of psychostimulants had no significant effect. This has been a concern since we started really looking more critically at pediatric bipolar disorder, whether or not the use of stimulants actually cause manic activation. And so it was comforting to see in the AHRQ study that the stimulants did not seem to have any effect on manic symptoms. Common side effects of the second-generation antipsychotics, as mentioned, include weight gain, elevated lipid and prolactin levels, a risk of diabetes mellitus type 2, and development of metabolic syndrome. So these are significant concerns, and the weight gain is very common in my clinical experience. And our monitoring for these metabolic syndromes in the field has been historically quite low. So it's a concern that we're using these medications in increasing numbers and not necessarily monitoring in the way we need to ensure that we're not exposing these youth to significant side effects that can have their own lifetime sequelae in terms of morbidity and mortality. Youth are at higher risk for acute and long-term side effects from the antipsychotics than the adults, especially with regard to the weight gain and then glucose and lipid abnormalities. So we really need to be checking baseline body mass index, waist circumference, blood pressure, a fasting glucose level, and fasting lipid panel. They can still cause the extrapyramidal side effects that the first-generation antipsychotics caused, including tardive dyskinesia, and those also should be monitored. So monotherapy tends to be uncommon due in part to the comorbidities as outlined earlier in this presentation. In one retrospective study, the mean number of medications per patient was 3, and only 23% of patients were treated with monotherapy. So using polypharmacy in the treatment of bipolar disorder, as you're seeing here, has become the norm rather than the exception. Unfortunately, there's little data directly comparing different second-generation antipsychotics or examining efficacy of the same second-generation antipsychotics at different doses. So we don't have great research to guide us in terms of what's the ideal treatment paradigm, even if we're going to be using more than one medication. Which ones do we use in combination, and at what dosages? In studies, placebo medication adherence is far better than second-generation antipsychotic medication adherence. So that's usually an indicator that the second-generation antipsychotic medication is causing more harm or more discomfort or more side effects than the individual patient is willing to tolerate, compared to placebo, which would typically not cause side effects, although interestingly enough, particularly with studies of youth, you do see high placebo response rates, both in terms of positive as well as in terms of side effects. There's little literature looking at how effective a second-generation antipsychotic is at treating depression associated with bipolar disorder. Again, I said that this is one of the hardest aspects of bipolar disorder treatment, is to try to get at the depressive episodes, which can sometimes be associated with significant suicidal thinking and suicidal attempts without triggering the manic side of the illness. So a separate head-to-head review found aripiprazole, olanzapine, and quetiapine didn't significantly separate from placebo for depressive symptoms. So while those medications have indications for the treatment of the acute phase of mania, it's less clear that they can help with depression. And then as stated, because the SSRIs are associated with manic activation, trying to figure out how to treat the depression phase of the bipolar illness when the individual is in the depressive phase is very challenging. And in clinical practice, I think there's probably the best sense that the anticonvulsant mood stabilizer Lamictal may show the greatest promise in treating the depressive side of bipolar disorder. So some evidence that combination therapies work when monotherapy has failed. There was a study by Bob Findling that reintroduced divalproex plus lithium in patients who didn't respond to either medication individually, and he showed an 89.5% response rate, which is a very high response rate as noted in any bipolar study. And then an open-label study found that the combination of risperidone plus Depakote or divalproex or risperidone and lithium led to response rates of 80 to 82.4% respectively, with remission rates of 60 and 64%. This was a small study, and 7 of the 20 participants in the lithium group dropped out, none in the divalproex group, which might indicate that lithium was more difficult to tolerate for the individuals in the study. So what's the difference between the youth and adult medication response rates? The second-generation antipsychotics had a larger effect size than mood stabilizers for youth. So whereas the traditional mood stabilizers still are the standard for treatment in adult bipolar disorder, lithium, carbamazepine or Tegretol, divalproex or Depakote remain the standard in the adult side of bipolar disorder, it's less clear that those same mood stabilizers are as effective in youth. And there's an indication in the research that we do have, with some limitations, that the second-generation antipsychotics may actually be more effective than those traditional mood stabilizers. So second-generation antipsychotics did cause more weight gain than mood stabilizers in youth, but not in adults. In youth, second-generation antipsychotics related somnolence or sedation was greater with mood stabilizers and was more likely to occur than in adults. So the youth had greater sedation from the mood stabilizers. They had greater weight gain from the second-generation antipsychotics, and they had less frequent akathisia, which is this restlessness, this internal ants-in-your-pants kind of a feeling associated with the use of antipsychotics. And they had less of that than adults, which is a good thing. And then there was the head-to-head comparison that was done by the Treatment of Early Age Mania study, or TEAM study. This was an 8-week randomized controlled trial that compared risperidone, lithium, and divalproex, or Depakote. There were 279 patients between the ages of 6 and 15 that had no prior medication trials, and that had been diagnosed at the time of the study. It was still using DSM-4 criteria for bipolar disorder, manic, or a mixed state. And the results showed that risperidone was more effective than lithium and Depakote. But the magnitude of the effect was influenced by the site, and there were, I believe, 5 sites in this study, as well as the presence of ADHD. So the biggest statistical influence was not which medication was being used, but which site you were enrolled in, as to whether or not you had a positive response to the medication. There have been questions about whether or not naturopathic treatments could be effective, but we have very little data to guide us. There was one open label study of fish oil that showed a modest benefit in treating pediatric bipolar disorder. And there was a study of flaxseed that showed no efficacy. It's not uncommon that parents will still use these approaches in combination with pharmacological approaches or psychotherapeutic approaches for that matter. So what are the treatment implications of all of these studies and what we know and what we don't know? The misdiagnosis may lead to treatments based on adult bipolar literature with uncertain long-term impacts. So again, the concerns about the impact of atypical antipsychotics particularly. Misdiagnosis also can impact etiological research, genetic counseling, and family educational interventions. By misdiagnosis, I'm talking about those youth that have been characterized as having bipolar disorder in that broad definition group. If we move quickly to the use of medications, we may miss opportunities for other therapeutic options, including psychotherapeutic options and family-based options. The primary treatment of bipolar disorder is medication, as noted by the ACAP practice parameter, but there's some support in the adult literature for the efficacy of psychoeducational therapy and relapse prevention, such as monitoring sleep, avoiding illicit drugs, managing stress, and staying on prescribed meds. You know, again, the kind of rainbow approach I mentioned earlier. Individual psychotherapy may support psychological development, skill building, and close monitoring of symptoms, and also encourage good self-care. Social and family functioning may benefit from interventions directed at improving communication and problem-solving skills. There may need to be academic accommodations and an individual educational plan, and community and peer supports as well as advocacy, knowing that this is a long-term disorder that can have functional impact that's very significant. Which brings us back to the other system of care sorts of considerations. So ensuring that these evidence-based interventions are available within the service array and accessible. Not just the pharmacological interventions, but that rainbow approach. Can you get that in your community, and how do you ensure that there is a workforce that's trained, coached, and supervised in providing those evidence-based services? How do you ensure that there are incentives for implementing these evidence-based practices, or money for training and ongoing professional development? Should all be part of the consideration if you're thinking about how to embed these evidence-based practices in your system of care community. Ensuring that care coordinators and RAP facilitators are aware of the need to access relevant evidence-based practices for depression or bipolar disorder or manic symptomatology. And building capacity for peer-to-peer support in the system and service array, which can really be helpful for adolescents who may be struggling with depression or bipolar illness. And then I'll just finish by highlighting some coming attractions for this evidence-based practice series. This is the second in the series. I've already released the evidence-based practice to the treatment of adolescent depression, and that webinar can be found on our YouTube channel. And upcoming, I will be presenting on the evidence base for the treatment of attention deficit hyperactivity disorder, obsessive compulsive disorder, post-traumatic stress disorder, anxiety, psychotic disorders, and impulse control disorders. And so stay tuned to the TA Telegram for information on when those products will be released. We're also working on guidelines for identifying and selecting an evidence-based practice, an introduction to implementation readiness, as well as a practical tool called Ready to Implement to help identify and select evidence-based practices and strengthen organizational readiness to implement. And then I wanted to include some family resources that were endorsed by the American Academy of Child and Adolescent Psychiatry, and bipolar disorder specific resources that are all available on the web. And then finally, including the references that appeared throughout this presentation. The content that appears in this webinar will also be available to be downloaded. That concludes our presentation.